It's now my pleasure to introduce Dr. Jonathan Gruber. He is the Ford Professor of Economics at MIT and also chairs its economics department. When Dr. Gruber joined us 2 years ago to speak at our Superagers Symposium, I was anxious about introducing such an esteemed person, and I wrote a very thorough introduction highlighting appropriately Dr. Gruber's many accomplishments. And when I was done, he stood up and said, "Thank you, Jennifer, for reading the introduction that my mother apparently wrote for you." So this year, I am going to let you read his credentials, which have been written down on the materials that are provided for you. But I did want to highlight a couple of things that have happened since that time. And by the way, he's talked to us about longevity before other people were talking to us about the crisis of longevity. So since we last met him, Dr. Gruber's accomplishments have become only more important and appreciated in the world. Some of you may have seen him on 60 Minutes. He's regularly called on as an expert in the media and elsewhere, particularly with respect to the economics of healthcare. When he last joined us, he was about to release a new book about how long-term health costs are addressed around the world, and he gave us a sneak insider perspective, which was very exciting. You can buy his book at the MIT Coop for the low cost of $150. $178, Philip says. So we don't really have a very big budget here at the Jenks Center, but we took a collection and we have a copy of his book, Long-Term Care Around the World. It resides in Philip's office under lock and key. You can borrow it, but you have to leave collateral. So it's such a treat and an honor to have Dr. Gruber here. I want to give a quick shout out to his wife, Andrea Gruber. I don't know if she's here today, but she was here last time. I just want to highlight her as someone who is also a friend to sensible and rewarding aging. She is on the board of the Massachusetts Senior Care Foundation and also serves with Minuteman Senior Services, who provide those Shine counselors that I mentioned earlier, and they provide our Meetup Monday lunches and so many other great things we do. It's a fabulous partnership with them. So Dr. Gruber will speak to us today about what the United States can learn from long-term care policy in other countries. Thank you so much.
You took my joke. That's awful. Yeah, so I'm glad that you mentioned my wife. It's the only reason I work on this topic. She was saying for years, why do you work on all that other stuff that's uninteresting? Aging is where it's at. So she finally convinced me, and I'm glad she did. And I've been working for a while now on these long-term care issues. And as was mentioned, part of that work, I wrote a book with Kathleen McGarry's at UCLA. We brought together teams of researchers from around the world to describe how long-term care is delivered in other countries. And we learned a lot. We have more to learn, but I thought today I would talk a little bit about what we learned about what long-term care looks like around the world. Obviously, it's a big topic, so I'll use my other joke here, which is the story that whenever I give a talk like this, where there's more to cover than there's possibly time, I remember the important story from my family, which is when my sister ran to the house and saw my father and said, "Dad, where's Mom? I need her." And my father said, "I don't know, can I help you?" And my sister said, "No, you can't help me," and started to walk away. And my dad said, "What do you need help with?" She said, "I need help with my math homework." Now my dad is a PhD in finance. So he was a little bit taken aback. He said, "Well, can't I help you with the math homework?" And she said, "No, I don't want to know that much about it." So I always tell this story to remind myself to not tell you more than you want to know. So we'll leave plenty of time for questions. But let me go through some of the things I've learned. First of all, the population is aging worldwide. Here we have the different colored lines are different countries that are represented on the right. The graph on the left is the share of the population that's over age 65. The graph on the right, graph on the left is the share of the 85 plus, the share of 65 population that is 85 plus. So the country's getting older, the world's getting older, and the oldest old are increasing around the world. The fact I like to give is, as of a couple of years ago, if you think about a U.S. state as being having a large, being an elderly state, having a large aging population, one might define that as 1 in 5 people being over 65. Well, as of 5 years ago, there were 3 such states in America. In 20 years, there'll be 43 such states in America. Okay, we are aging enormously, as is the rest of the world. We're not unusual. Okay, the key concept we think about assistance in old age is activities of daily living: bathing, feeding, toileting, etc. So what we know is that limitations, it should say limitations in ADLs, are concentrated but spread with age. So if you look at 65 plus, still 3/4 of people 65 plus have none of these limitations. They can toilet, they can feed themselves, they can bathe, etc. About 8% have no ADLs, what's called an IADL. That's the orange thing. That's things like being unable to drive, being unable to run one's own finances, things like that. So more moderate limitations. Still only 8% have at least one of those. And then you start to see people with more limitations, but only about 10% of the population has 2 or more ADLs, which is the qualification for being in a nursing home. Okay? If you look at 85 plus, it's a very different story. Almost a third of people 85 plus have 2 or more ADLs, which qualify for the nursing home, and a minority have no ADLs or IDLs limitations. So basically, this graph, which shows the 85 plus share going up, should be going with this graph to say we're entering an era of much more intensive need for long-term care services. Now, the other thing, this is an American fact, elderly income is low and concentrated. The median elder, the typical elder, that's the 50th percentile, has an income of $35,000, and if they're over 85 plus, $25,000. That is low income. Okay, their assets, this includes their housing, are around $200,000. Now compare this to the cost of a nursing home of about $120,000, $150,000 a year, or full-time home care, or heavy home care, which can be on the order of $50,000 a year. People cannot afford this long-term care out of their regular means. This is something that people are going to need assistance with as they age. This is not something the typical elder will be able to pay for. Moreover, once again, these are U.S. facts. Income is lowest for the oldest and most disabled. So if you look at, we've got 3 columns here. We've got the total, we've got very poor, which is less than half of the typical household's income, and moderately well off at least, which is more than twice the typical household's income. Okay, and then the rows are how sick people are. So for example, take the top row. That's people with no limitations. Okay, no limitations. That's 71% of the population have no limitations over 65. 14% of them are poor, 20% are well off. Now go down to the bottom here. People with 3 or more ADLs. Okay, that's 8% of the population, the least able population. 40% of them are poor. 40%. Okay, and only 7% are well off. Once again, people, as they age and become more limited, do not have the resources in America to pay for long-term care. The government needs to get involved if we're going to have long-term care be affordable for people and not, what, it's not working?
It's running out of battery.
If we're going to have long-term care be affordable and offer our elders the dignity they deserve, we do something about this. I had an editorial after COVID, or during COVID, which highlighted that during COVID, we spent $3 trillion and shut down the U.S. economy, largely to save the lives of our nation's elders. Okay, they're the group most affected. Yet, COVID's over, we go back to disrespecting that same group and not giving them the resources they need to live with dignity. That's ridiculous. Okay, we need to take the problems of aging as seriously outside COVID as we did during COVID. Okay, now we are spending more on long-term care in the U.S. In 1990, we spent less than 1% of GDP on long-term care. Now we're spending about 1.33%. Okay, but that is pretty low by international standards. So in the U.S., in 2019, we spent 1.3% of our GDP on long-term care. The average nation spends 2.1%, highlighted by the Netherlands, the league leader. They spend 4%, 1 in every $25 in the Netherlands goes to long-term care. And you can see that it's grown a lot, but it's once again not grown much in the U.S. In the average country, their spending on long-term care from 2000 to 2019 went up by 60%. Ours went up by only 17%. So in 2000, we weren't that far off the average. By 2019, we're very far off the average. Okay? Other countries are recognizing the aging population to require more spending. we're not. Okay, now, one thing that's common around the world is that financing of long-term care, recognizing the limited means that elders have, is mostly public. It's mostly government financed. So if you look in every country in our sample, and these are just a set of countries in our project, okay, in every single case, more than half of the spending is government financed. And a minority, except Singapore is one exception, a small minority, a quarter or less, is out of pocket. You also notice private insurance is zero. Basically, there's a thing called long-term care insurance. Some of you may have it. It's not a very robust product. It's not very popular. It's not really solving the problem. This is a problem that's either met by government spending or people paying out of their pocket worldwide. Okay, now here's the other piece to recognize though. What I said here, these numbers, this is all official spending out of pocket, okay, for long-term care. Okay, but most long-term care does not come in a spent form. It comes in informal form. It comes from our spouses, our children, our neighbors. If you look at 65 plus people, of all the hours of care they get dealing with their ADLs, 69% comes from informal caregivers. So the vast majority of care that's given to elders for their long-term care needs is informally. Even for the old, 57% is informal care. Nursing home care is 13% and 18%. And then a large share have both formal and informal home health. So if you look at those 65 plus, 82% are getting some informal care. Okay. Why does that matter? Because that informal care does not come for free. Okay. Informal care is often given by loved ones who are eager to help, but that comes at the cost of maybe not being able to have a job, or the cost of other things. Those costs should not be ignored. Okay, when we talk about the share we spend on long-term care, we should incorporate those costs, and I'll talk about that. Now, there is wide variation in the types of care people give worldwide. So, for instance, compare the Netherlands to the U.S. So, in the Netherlands, 29% of people are in a nursing home. In the U.S., it's 13% of those 65 plus. Okay, in the Netherlands, only 19% of people get care only informally. Less than 1 in 5 people who need care get it only from informal caregivers. In the US, it's 69%. Okay? On the other hand, in the Netherlands, 29% of those who need care get it from formal home caregivers. In the US, it's 5%. Okay? So basically, we are relying a lot on informal care, okay, and relatively little on formal care. Okay? And once again, that makes long-term care seem cheap from a pocketbook perspective, but not from a social cost perspective. Particularly when it's children, particularly in an era when we need, with shrinking population, we need more people out in the workforce. And people need to be able to deploy their skills to what's best. And if where they're most productive at is working somewhere and hiring someone to take care of their elder, then that's something we certainly, or having someone paid for to take care of their elder, that's something that may make our economy more productive and, quite frankly, happier. Okay? Now, what about those care providers that we do have? The minority of people who get formal care. Well, here's an interesting fact. If you look at both the nursing care industry and the home care industry, if you look at higher skilled workers, okay, and these are the only countries we have the data for, we do pretty well. The typical highly skilled worker in an elder care setting makes about the same as the national average wage, which is pretty similar to other countries. Okay? But the lower skilled workers make way less in the US than other places. So in fact, the difference with our long-term care workforce is our highly skilled workers are being compensated roughly like other countries. It's our lower skilled workers that are being compensated much less. Okay? And then this is once again another way to say how countries differ in how they deliver long-term services. So this is basically, once again another way to look at how they differ and how they deliver long-term care services. So what are the lessons for the U.S.? Okay, and once again, there's more in the book. I don't know why the book. I see $0 from that money. I don't know why the book costs so much. Don't buy the book. Just whatever. It's whatever. If you come borrow the book, don't buy the book. Okay. So basically, what do we know? We're aging and becoming more disabled. Okay, it's more critical than ever. Not every. I'm also aging and becoming more disabled. I should say ever. Elders are not financially equipped on their own to bear the risk of the median 85-year-old would have to use their entire wealth for 1 year of nursing home. And many elders have faced the risk of a longer stay than that. We have a relatively high share of care delivered informally. And here's the thing, there is strong evidence showing that caring for aged relatives means you work less. And indeed, we have 10.6 million informal caregivers in the US. We estimate in this book that that's $150 billion they could be out earning in the workforce that we're giving up because they're providing informal care. Now, let's be clear. Many people may choose that. They may prefer to be providing some informal care than working, but they should have the right to choose, not be forced to provide some informal care when they could be earning a lot elsewhere. And then finally, the quality of our care is harmed by underpaying low-skilled workers who provide that care. Okay, so that's the landscape. What does this mean for where we should go? I'm a policy guy. What does this mean for where we should go? Well, let's talk about what we do now. Okay, basically, let's think about three categories. There's home care, there's nursing homes, and then something I want to really burn in your brain. There's this third category, congregate living. Okay, and I want to talk about these three categories. Home care, basically how does it work is if you are disabled and low income, you can qualify for Medicaid home care, but you're not guaranteed to. Okay, in states like Massachusetts you are, but in many states you are not. Okay, you're not guaranteed home care. Even if you're disabled and very poor, you could be on a waiting list. You might not get it. That can result in a huge burden on informal caregivers. Okay, so that's point one. Let's go to the bottom point. You are, if you're poor and disabled, you are entitled to a nursing home in every state. But it won't necessarily be a good nursing home. We have a huge mix in the quality of nursing homes. We have a lot of low-quality nursing homes in America. We have a lot of high-quality nursing homes in America. Okay, but you're not entitled. You're entitled to nursing home stay. You're not entitled to a quality nursing home stay. And then we have the middle thing. Okay. How many of you live in assisted living facilities? How many of you have been to an assisted living facility? Okay, they're pretty awesome. Okay, my wife's ready to move in now. They cook. It's like there's activities. They cook. Okay. 95% of Americans cannot afford assisted living facilities. Okay, so we've solved this problem for the rich. Okay, we have not solved it for most Americans. And what does this result in? This results in this bad cycle. Okay, and the cycle is elderly people who really maybe shouldn't be at home and maybe even don't want to be at home stay home because they think the only alternative is a terrible nursing home. So you combine the fact that the only alternative is a nursing home with the fact that many are bad, and the typical elder is scared of leaving their home. They feel stuck because they think the only place they can go is a crappy nursing home. Now, the truth is, in many cases, they can go to a good nursing home, but they don't know that. Okay? So this results in many people not being where they're best served by their family and by society. So I've laid out a proposal. I'm working with the Brookings Institution on this proposal. This proposal really has three legs. The first is universal home care. Everyone on Medicare, virtually all of you in this room are on Medicare, everyone on Medicare would be entitled to home care. You don't have to be poor. You have to be disabled. It's for those who are disabled, those who need it. You can just have a companion. We've got AI for that. Okay, this would be if you need care with your activities of daily living, every American would be entitled to a universal home, every Medicare recipient entitled to a universal home care program. Okay, but you would contribute. So instead of what we do now is we say in Medicaid, it's sort of a flip of the way we do it now. The way we do it now in Medicaid is we say, if you're really poor, we'll let you have this. We want to flip it and say, everybody has it, but as you're well off, you've got to contribute. So it's really, it's a similar idea, but it's really a different framing. And think of it as people with means are contributing to make this system work. We want to improve the quality of care. Okay, now how do we do that? The first is, the simple thing is, the number one predictor of quality care in a nursing home is staffing ratios. Okay, it's not really that hard. I mean, the infrastructure matters, but the truth is, this is largely a human endeavor. Okay, we need to have minimum staffing ratios. We need to have regulated staffing ratios that ensure that we have enough staffing for all elders and those who need nursing facilities. We don't have that right now. But we also have another problem. You know, one thing my wife said that really influenced me a lot was she said to me, you know, she works at a nursing home, and she said she thinks that America would be a better place if everyone had to be a CNA for 2 years and no one was a CNA for more than 2 years. Okay, has to be a CNA or the nurse assistants, the ones who do the dirty work in the nursing homes. Has to be because it lead us respect for our nation's elders. Okay, shouldn't be because it's an underpaid job. Now, one option would be to raise the pay. That would be very expensive, and it's not really on the table. To raise the pay enough to make that a middle-class job would be really prohibitively expensive. The other option, okay, and this is something else that started since I was here last, is to create a career ladder. Here's what we did in Massachusetts. So my wife said that to me. It got me thinking. I did a little math exercise. I said, take a CNA. In a nursing home, there's 3 levels of care. There's CNAs, LPNs, and RNs. RNs are registered nurses, LPNs are licensed practical nurses. LPNs take 1 year of schooling. So I said, take a CNA, pay for 1 year of schooling, and pay for them to have 50% of their time off. What would that cost? That would cost $25,000. What would they get out of that? A $17,000 per year raise. That's a pretty good investment. So we surveyed, I worked with Tara Gregorio, who runs the Nursing Home Association in Massachusetts. We surveyed all CNAs in Massachusetts, said, do you want to be an LP? And they all said, yeah, we just can't afford it. We can't afford to take the time off. We can't afford the schooling. So we worked with the state. We got a $6 billion allocation from the state and set up something called the Career Ladders Program. You can look it up online. It's through an organization called Social Finance. And here's how this works. Nursing homes nominate CNAs. We then pay for their tuition and pay for them a 50% time off while they do a year of schooling. Then they go back to those nursing homes as a much higher paid LPN. Okay? And here's why this is great. Here's why I think this is sort of a win-win. One win is we need more LPNs. And the only reason this couldn't then go on and be an RN. You can have the same thing all the way up the chain. The second win is it makes CNA jobs more appealing. Okay? Think right now if you're someone who doesn't want to go to college in Massachusetts, and you think about your options. You can go work at Starbucks or McDonald's, or you can be a CNA and make almost the same thing. Who's going to choose being a CNA? But if I tell you, if you're a CNA, within 3 years you'll make $40,000 a year, whereas at McDonald's you'll still be making $25,000 a year, then maybe you'll become a CNA. So maybe this has this effect of pulling people in, and that's the hope. Okay? And then the last piece of our plan is more congregate living options. We need assisted living for the masses. Now let's be clear, it's not going to be as nice as assisted living y'all went to. Okay? We cannot afford to have every elder have the right to have a $10,000 a month apartment. Okay? But that doesn't mean we can't do things that take advantage of congregate living. We have something in America called the 202 housing program, which is a program which basically builds apartment buildings, I think it was dorms, for elders to live in with housing subsidies from the U.S. government, with a nurse and a social worker in place. This could be an option, could be very attractive to elders, the place to be. It would help with elder loneliness. It would reduce the cost of caring for aging. And maybe, just maybe, people be less scared about leaving their house if there's someplace decent to go. So that is really sort of where we're pushing. That's what I'm pushing policymakers in Washington. I think and I hope this will be a big issue in the next round of presidential elections. And I think that I'm naively hopeful that there could even be some bipartisan agreement on this, because everyone's got a mom. So anyway, that's what we're pushing, and I think we have about 15 more minutes. So I'd love to take some questions about what I said. Yeah.
Any comments on immigration?
Could you just wait for a mic?
Oh.
Scott, do we have another?
Here, I can yell.
Any comments on immigration?
Lots of comments on immigration.
I'm going to make you take the mic just because the local actors.
Okay. Yeah, I actually did a research paper on this. So what we did is we looked at, across cities in America, what happens when more immigrants arrive to the care for and health of the elders. What we found was that for every 1,000 immigrants, you get 150 more healthcare workers. And if we raised immigration by 25% in America, we would save 5,000 lives a year of elders being cared for by these extra workers. So let me put it another way. The current administration has talked about deporting all Haitians who are disproportionately in long-term care. If we deported the 330,000 Haitians in America, we estimate 9,000 elders every year would die because of that. So immigration is a key part of this.
I have a question, and I'm not quite certain of all the facts, but you have Aetna that owns CVS and owns physical doctors' practices. And it's a vicious cycle of they control too much for care in the United States. How do we address that in America?
I mean, now you're getting beyond long-term care to the general problem of healthcare, which is something I've spent my whole life working on before my wife convinced me to work on long-term care. So I spent my time working on general healthcare. We have an excessive concentration of healthcare in the U.S. We'd like to think we could use the regulatory tools at our disposal, antitrust laws, to not allow these mergers to happen. But it turns out to be really hard. One reason is because those antitrust laws have a threshold. And so what companies will do is, when there's small companies below the threshold, they'll buy them up and take them before they can become big enough that they're subject to that merger regulation. Honestly, I thought about this for 35 years now, and I think the only answer is to do what the rest of the world does. We need to regulate the prices we pay for healthcare. Every other developed country in the world recognizes what economists have known forever, which is that when a market doesn't function, the prices will not be set appropriately. What do I mean by that? If we think of our standard Adam Smith invisible hand market, okay, it's one where people have perfect information, where they can shop across lots of options. Okay, none of that happens in healthcare. Okay, when you're in the back of the ambulance, you're not shopping across hospitals. Okay, if you get sick in Nantucket, you're not shopping across hospitals. Okay, we have a situation where we have broken markets, and broken markets need to be regulated, and that's what the rest of the world has done, and we do that in the U.S. And I think that's the way we're going to get at these problems. Yeah. I think the guy with the mic is in charge.
All right. Given that a large majority of the care being provided in the U.S. is from informal caregivers, can you speak a little bit to the efficiency of paying those informal caregivers and converting them to a little bit more formal?
That is a great question and a critical issue as we do policy, which is what we have in Massachusetts, the PCA program, is essentially what's called the Consumer Directed Program, which is basically, instead of saying you can only get people come to your house, say we give you money and you can actually pay a caregiver of your choice to take care of you. That has enormous advantage. People like it a lot better. As enormous disadvantage, it's way more expensive. Okay. Now Massachusetts, just to fix that idea, on our PCA program, consumer directed, we spend $2 billion, this state, every year on consumer directed home care. That would be a lot lower if we said, fine, we'll give you home care, but only if you allow a formal care worker to come into your home and deliver it. Okay. So it seems like a good idea. Well, people in limited, let's just pay them. And in a world of unlimited resources, it would be a good idea, but it's very expensive. So we have to ask ourselves, is that how we want to allocate our dollars? When the federal government is about to put a $3.5 billion hit on our state in terms of cutting back its support for healthcare, do we still want to be paying informal caregivers for that care? Maybe the answer is yes. I don't know, but we have to recognize that in a program where you pay the informal caregivers, that has a cost, and we have to ask if that's where the state wants to spend its money. Yeah.
How can we help you with your proposal?
Write your congressperson and your senator, and tell them that this is actually Ron Wyden and the Senate Finance Committee are actually taking this issue very seriously. We're going to come out with a proposal, and I think you can tell your congressperson and senator to pay attention to that process and be a part of that.
I'm looking to the future to predict what's going to happen. Not one of those countries you mentioned reproduces itself. Birth rates less than 2% in all of them. Worse perhaps in Japan, which has got the highest percentage value. Secondly, AI is going to make a lot of people unemployed. How are we going to solve this?
Well, look, let's start with the birth rate thing. We are shrinking. We're nearing, I think the estimate is global population will peak in about 30 years and then start to fall. It's not obvious if that's good or bad. Because the fewer workers you have, the more productive each worker can be. On the other hand, more workers means more demand for goods. So there's very well established economists arguing either side of that debate. On the AI, once again, we I'm as scared by AI, probably more scared than you are. Okay. That said, we always have this debate about technology of, oh my God, it's going to cause mass employment. The car will cause mass unemployment of horse-drawn carriage drivers. Okay. The weaving mill will cause mass employment of people who do it by hand. And it always turns out that that's not true. It always turns out that the new technology creates new jobs we hadn't thought of. So with AI, it seems like, well, that can't be true because AI is not going to create new jobs. But there's a field called data scientist that did not exist 30 years ago that now has 250,000 people in it. Okay, that wouldn't exist other than the data processing you need for AI. So we don't really know. I think what we know for sure is AI is going to be inequality producing. That's what we know for sure. And in particular, what's interesting is not necessarily that the bottom level of jobs will go away, because in some sense, those are jobs AI can't replace, the gardener, things like that. It's the sort of lower middle that's going to go away. It's a sort of lower white collar jobs that are at risk, and that's going to be a class that needs to be helped and retrained. But I think the point is, here's the way I think about it, which is we have to get on top of this. So here's the thought exercise I have. You probably all feel about social media like I do. Okay, bad. Think about a thought exercise. Imagine I took you back 2001, knowing what you know now, and said you can regulate social media. We would have done things a lot more differently. We're at that moment with AI. We don't want to be giving this talk in 10 years and saying, God, I wish in 2026 we'd done that. We need to do it. We need to really take chances. And even if it, everyone says, oh, don't do anything that'll slow the growth of AI. Well, you know what? I'm okay with slowing growth of AI a little bit if it protects us against very bad outcomes.
When you were talking about the countries worldwide study that you did, I noticed that there weren't any countries that were either Latin American or African. And I was curious if that was possible to have seen the numbers for those countries. And then coming to further to the question that someone asked about immigration, and you made an example of, a Haitian CNA and all that sort of thing. Normally, these CNAs are drawn from those countries that I didn't see represented in the study. Yep. So then I'm curious, what makes for that gap?
First of all, the countries we have is because that's the countries where we happen to have friends. It really was like, I know people at these universities, let's study these countries. We also wanted to focus on the developed world as a comparison for the US. Really, but I think you're raising a fascinating question, which is for the last 50 years with developing countries, with Latin American, African countries, some of the poor Asian countries, we've been very focused on kids and very focused on keeping people alive, keeping them from starving. We're getting pretty good on that. Now we've got a new problem, which is they're aging. A good problem to have, because before people just died, they didn't age. It's a good problem to have, but here's the challenge, which is these are countries which traditionally dealt with aging through informal networks. Basically elderly were taken care of by their family. The families live together. The kids are now moving to the cities. And this is going to be a huge new problem. Developing countries, we've been facing the problem of lower informal care for decades in the developed world. This is a new problem in the developing world, which is they're going to have, and there's studies my colleagues at MIT showing that there's growing elder loneliness in places like India because the kids are moving away and they have no resources. This is going to be an enormously important issue in the developing world as well.
Hi, my name is Nina. In your proposal, the third option, which is the aggregate living, why would that require policy change? Can we do that now, or is there somebody taking the initiative to start that kind of?
Yeah, it's a great question. So basically, there's a number of barriers now. So once again, no one's stopping it for rich people. I mean, assisted livings are bumping up everywhere. What is the barrier to making it affordable? The bottom line is affordable would still mean pretty expensive. You're not making this for $200 a month. It's going to be $1,000 to $2,000 a month. For many people, they just can't afford that. Remember, the median 85-year-old's income of $25,000 a year. So talking about their entire income going to rent. So it really is. So there's two issues. One is about giving them affordability, and that's about giving them. Now, we do have public housing programs We give them vouchers, but they're a tiny fraction of those eligible. The second feature is sort of the coordination of putting these elders together and coordinating, having a social worker, having a nurse. That's hard. The private market is not interested in doing that. That's where we need some government intervention to make that happen. Yep.
Yes, I wonder if you could address the rising cost of pharmaceuticals, especially international versus domestic pricing.
Yeah, look, once again, this is a broader healthcare issue, and it's fascinating. Healthcare prices are rising everywhere, but the talk is all about pharmaceuticals. So we pay 3 times as much for pharmaceuticals as the rest of the world. Guess what? We also pay 3 times as much for our surgeries as the rest of the world. No one's talking about that. Why pharmaceuticals? Well, there's 2 reasons. One is it's the most transparent price in the healthcare system. We have no idea what surgery costs. We know what drugs cost. The second is those goddamn ads. Okay? And I swear that when history is written, the pharmaceutical industry may regret advertising. And my particular story about this, which I apologize I told last time I was here because I love it, is in particular, my kids were growing up in the first generation of pharmaceutical ads. And I got so tired of my son asking me, what's Viagra? And why is that man throwing that football through the tire swing over and over again? And then I told a friend who's a doctor in Lexington, told me the following true story, which is an 8-year-old came into his office and said, I'd like to talk to you about Cialis. And the doctor said, why? And the kid said, well, I was watching football and they said, talk to your doctor about Cialis. So basically, I think that's the reason people are focused on pharmaceuticals. Our prices are much too high, just like they're much too high for everything else, and they should be regulated. Here's what's interesting. If you regulate pharmaceutical prices, there is a trade-off because there's real innovation in pharmaceuticals. And if there's lower prices, they will do less innovation. I've argued that you can solve that problem easily. I have a book called Jumpstarting America with a Nobel Prize winning co-author, not for our book, for a different book, Jumpstarting America. And we argued that that in fact, there's an easy solution to that, which is regulate the prices and take that money and recycle to NIH, which does the basic research that gives birth to drugs. But the truth is there's way more innovation in drugs than there is in hospitals. Why are we so busy talking about regulating drug prices? We're not talking about regulating hospital prices. CEOs are making outrageous amounts of money. The prices are incredible. Why are we so focused on drugs, which is actually the one innovative part of the healthcare sector? Why is that the part that we're focused? And I gave the reasons why, but I'm not sure it's the right answer.
Back to the assisted living for the masses.
I know where I'm looking. Oh, there you go.
I was just curious. There's a group in Newton, I think it's called Opus, that
Yeah.
supposedly has cheaper
Yeah,
good assisted living. Can you talk about that? Has it been cheaper? Is it good? How's it working out?
it's a great question. I need you. I've had on my list to do a field trip there for a while, but I haven't gotten there. It's a great question. Once again, cheaper. I don't know how cheap, and you have to say what's affordable. Remember, affordability is hard. We have this affordability debate. Let me give you a secret. Affordability means nothing. Okay, there's no economic definition of affordability. It's how you feel, right? And so affordability is a really hard debate because someone might say, gee, if I'm paying $500 for health insurance, it's unaffordable. And I might say that's a great deal, and so basically that's the trick with this whole affordability. So I don't know what it costs and whether it's affordable.
The problem is corporate ownership. It sucks money out of everything in the system and doesn't provide a doctor or medicine or anything. It just provides money for the corporate owner.
I think that there's a lot of evidence that its private equity is, for example, buying things like nursing homes, quality is going down. To be fair, okay, the most expensive source of healthcare in the world is Mass General Hospital, a non-profit organization. Okay, so people like to brag on for-profit, but it's not just for-profit. The answer is, instead of picking a fight which goes to the core of American capitalism, which is saying we're not going to allow for-profit folks to own things, we're never going to win that fight. Let's pick another fight, which we also might never win, but at least it's feasible, which is say, let's just limit the prices they can charge. We don't care who owns it if they're charging reasonable prices. I'm fine to let them own if they're charging reasonable prices. But just switching ownership is not going to solve this problem.
Good afternoon. Hi, Dr. Gruber. Really appreciate your. It's very informative. I'm with the Gables at Winchester. My name is Daniel. I've asked Philip for your book for about a month now. He hasn't given it to me. He hasn't responded, but I look forward to reading it someday. On Netflix, there was a show. It was called Live to 100. It's the secret to the blue zones, and they have areas like Costa Rica, Sardinia, Okinawa, and I noticed on your slide Singapore. And in the show, Singapore seems to be thriving. And one thing that the government does, it incentivizes the children with tax incentives when the parent lives within a certain radius. My question to you is Singapore a model that we should be emulating? Thank
Singapore is a fascinating case. Great question. Singapore is a fascinating case because they really are an outlier in how they do things. They have much more reliance. Essentially what Singapore does, instead of insurance, they have mandated savings. They mandate you save a huge share of your money and then you pay for stuff out of pocket. I don't know about these paying kids to live near the elders. What I do know is the other thing that's fascinating about Singapore is that they have all public housing. Virtually all housing in Singapore is publicly owned. So they solve this congregate living problem because they basically make it possible for elders to live affordably in these houses. So that is a big difference in Singapore as well.
Hello, thanks for your talk. I've noticed that other countries say they got rid of lead out of paint much earlier than we did, and they regulate the chemicals that go into their food and environment. And I was thinking that when the government has a price or sort of has a well, let's just put it this way. I'm sorry. If the government has a stake in the health of their people, they're more willing to put those regulations. And if they're paying for the health care, then they have a stake in keeping that health care lower.
Yeah, you know, look, it's a good question. You know, many people, when we were working on the Affordable Care Act, many people said, well, we can't cover people till we solve the cost crisis. And I said, that's sort of backwards. We're not going to want to solve the cost crisis until everybody's covered. And that's sort of, I agree very much with that perspective.
I think we're good. Dr. Gruber, thank you so much. And I had this idea that after today, I think we'll use the book as a fundraising mechanism and we'll charge to loan the book. But thank you so much. And I want to thank Dr. Wetstein and Dr. Jones. Dr. Wetstein stayed with us all day, which is awesome, and really appreciate their participation. We're going to have some lunch, but I just had a couple closing remarks. I want to thank all of you for your kind attention, for your really great questions. And you are a big part of why we're able to get great speakers, because we're a fabulous audience here. And we should all feel really proud. So I hope you've enjoyed this day of learning and exploration. We've benefited from some of the latest thinking about longevity and its challenges. And hopefully we all have some good thoughts about how we can ensure that our own hopefully long lives are more productive and happy and meaningful. And also about the part that the Jenks plays in that and what our role is as contributors and participants here at the Jenks. So let's leave being advocates for our culture, institutions, and policies to better serve this growing population of older adults, to live better lives for ourselves, to be better citizens of the community and of the world. So thanks again for your kind attention. Thank you so much for our speakers, and hope you all stay and enjoy lunch and good conversation. Thank you.